we identified two mechanisms. The first one is eye tilting that may take place at docking or after docking. If it takes place at docking, the surgeon is aware of that. But if the eye moves after docking during laser treatment and there is no online OCT providing the image of what's going on, the surgeon might be unaware of that and the laser might break the posterior capsule. The second mechanism is related with the very laser activity that creates bubbles. The beginning of the fragmentation, those bubbles will enlarge the volume posteriorly to the lens nucleus, and enlargement on volume will push the posterior capsule backwards at a time where the cataract stiffness will prevent any anterior movement, and this might break the posterior capsule. We should prevent this in two ways. First, we might regulate our laser so that it doesn't create that large amount of bubbles. And if we dock the eye properly with a cushion or with a water pillow between the patient interface and the cornea, this will prevent corneal folds and will entitle us to use lower energy of the laser. Another way is to increase the posterior safe zone to 1 millimeter. This is what I do regularly. My posterior safe zone is 1 millimeter, and I never had a posterior capsule break because of the gas fluid. Techniques are related with good patient selection, good patient positioning before surgery in order to prevent suction losses. And then the docking is the most important part of the procedure. And I like to have a water pillow between the patient interface and the eye. This can be obtained virtually with any laser if we dock the eyes properly, removing the air from the space between the patient interface and the cornea. This is crucial, especially for capsulotomy, but also helpful for lens fragmentation and for corneal incisions. We should know our cartridge. We should examine our cartridge, trying to understand the engineering behind that cartridge, and also asking for explanations from the industry, because there are side cuts, there are bevels, there are cartridge reinforcements, and all those issues influence the way we implant an intraocular lens. For instance, the cartridge mouth bevel will direct the lens posteriorly when the optic opens inside the eye. And if we are placing a three-piece IOL intended to be placed in the sulcus, this might be difficult with such type of cartridge. If the cartridge has a side cut, this will absorb part of the elastic force of the lens at opening, but we need to enter the eye completely with the side cut completely inside the eye, otherwise the lens will open outside the eye. So know our cartridge is the first issue.